How's it going, modern manual therapy viewers? Dr. E here, back with another Q&A, this time from a participant of a recent TMJ class. So he says, thanks so much for the course a couple weekends ago. It was fantastic. I'm enjoying learning how it fits in with our practice and with the clientele we see. His follow-up question is, many of the cervical patients I see are older, 65 plus, and having issues related to stenosis and having very minimal side bending and poor tolerance to side loading. Are you still using the retraction and side bending techniques with them? I usually think about closing down on the irritated side increases symptoms and opening should reduce those symptoms, but I'm certainly open to changing that. So that's a really good question, Ethan. And I think there's a misconception that um, these absolute rules of a central foraminal stenosis or a lateral foraminal stenosis in potentially an older individual always needs to be unloaded or gapped, and that it's always a space occupying lesion or a space occupying issue that is a result of the pain. But remember, a lot of these things are like gray hairs on the inside or skin wrinkles on the inside, and a lot of these degenerative changes are really just the kisses of time. So what I would say is more of a general truth is that your average older individual is probably stiffer. So if they're stiffer, I would say it's even easier to load them to end range. It's actually much more difficult. A question I actually ask in my spinal manipulation classes is, manipulate? Would you rather manipulate someone who's stiff or manipulate someone who's lax? And the thing is, I've worked with a lot of dancers and gymnasts, especially because my girls were all competitive gymnasts. So I've worked with a ton of competitive gymnasts working in their gym for several years, and they still responded to mobilization, manipulation, and particularly end range loading. It's just that it's harder to end range load someone who is very, very lax. So if someone is stiff, again, remember, I've said this even in the course that I taught you, the indications and contraindications for mobilization, manipulation, and end range loading are the same. So you have to ask yourself, would you mobilize someone who is 65 plus and generally stiff? Certainly if they have osteoporosis or any kind of bone density concerns. If you wouldn't aggressively do a grade 3 or 4 mobilization, end range loading may not be in the cards, especially with overpressure. However, I think one of the misconceptions also about end range loading is that a manipulation in particular is that that's a single treatment and it's a lot less irritating. In fact, I got into a good debate with someone who teaches dry needling and spinal manipulative therapy on LinkedIn, and he was saying, "Well, I concede all your theories about ISTM and dry needling and manipulation and repeated in-range loading all having the same mechanism. That's what I teach. It's what I believe, that they're all novel inputs to the central nervous system. They reset some sort of learned neurotag or learned behavior that a position or movement or functional activity is threatening. You reset that alarm, and then temporarily the patient has increased pain and movement thresholds. However, his thing was repeated loading of the spine in particular is more likely to be irritating because it's more, you do it so often versus a manipulation is just one time. I would just say, what's the difference between repeatedly loading the spine in flexion or repeatedly loading the knee in flexion, repeatedly loading the knee in extension? No one ever says, hey, don't extend your knee more than 10 times an hour because you might irritate your knee. I mean, all it is literally is passive loading with a little bit of overpressure at the end. Our joint, it's well within the joint's tolerance to do it hundreds and hundreds and hundreds of times a day, even passive overpressure. Can someone get sore from it? Sure. But that's why you always teach the stoplight rule, right? It's always red light, yellow light, or green light. Just be caution with the yellow light. If red light, if it peripheralizes or it stays worse for more than 3 to 5 minutes, you can't walk it off. Sure, you just irritated it. You didn't damage it. But in general, if you would mobilize or manipulate someone, you would do repeated end range loading. Don't be surprised if um, just because someone is older, maybe they're very, very kyphotic, that they still may respond to repeated cervical retraction extension. just because someone is older and they have very stiff hips, and maybe they even have like a lot of crepitus, like it literally feels like cogwheel when you passively range it, you may not be able to improve their motion rapidly just due to actual cases of time, but you can always modulate pain rapidly because um, pain is just a perception. It's an output from the perception of threats, and we can change perception rapidly. We can't always change structure rapidly. So I hope this answers your questions, and I hope you do try to repeatedly end range load patients and not always go for, let's go gapping because someone's older, or let's try loading because someone's younger. Because again, you'll be surprised, especially if you haven't tried loading to an older individual, that might be the novel strategy that they need. If you like this video, make sure to hit subscribe and share, and make sure to submit more questions if you want them answered like this.